Hi, I'm Dr. Neema Jamshidi, an interventional radiologist at UCLA. I'm excited to talk to you today about the endoAVF, a minimally invasive option for hemodialysis fistula creation. So a little about me first. I received my MD and PhD at UC San Diego, which was followed by an internal medicine internship at the UC San Diego Medical Center. I then came up to UCLA for my radiology residency and continued at UCLA for subspecialty training in vascular and interventional radiology. And I'm currently an assistant professor at the David Geffen School of Medicine at UCLA in vascular and interventional radiology, as well as principal investigator of the Systems Imaging and Modeling Laboratory. So an outline for the topics that we'll try to touch upon today. This is not comprehensive, but given the short amount of time, I will try to provide as much information as possible in order to give you some context for the bigger picture of CKD, where hemodialysis fits in, and where this endovascular option fits in. And then in terms of the procedure, of course, what to expect before, during, and after. The kidney are paired organs in your lower back, and most folks know them for their filtering functions, getting the toxins out, so to speak. They do a lot of other things as well, keep balances of your electrolytes, drug disposition, drug metabolism, normal metabolism, blood pressure, a lot of different things. So renal replacement therapy, when the chronic kidney disease progresses, becomes very important for patients. So some statistics for CKD, or chronic kidney disease. The CDC estimates that 90% of people with CKD don't even know that they have it. The prevalence, it affects nearly 700 million people globally, about 38 million people in the US. And unfortunately, its mortality, 1.2 million deaths per year from CKD, and nearly 85,000 deaths per year in the US. To place that in context, that's more than prostate or breast cancer. So a big picture of renal replacement therapy, we can lump it into three categories. Kidney transplant is the gold standard, but not every patient is a surgical candidate. And even if they are a candidate, it may take a while before the suitable donor is found. So in those cases, in the intervening period, there may be a need for other means of renal replacement therapy. Blood filtration is one, and filtration through the abdominal cavity is another, just considering those two main groups. We're going to focus on hemodialysis, which is blood filtration, and really the two principal means of permanent, quote, permanent access is the AV fistula, AVF, or the AV graft, AVG. I'll touch upon the tunneled catheter in a moment to explain why that's not an optimal option. So the reason these catheters are not optimal for long term is that they have significant complications that are then very difficult to deal with down the road, notably central vein stenosis, which can limit the ability to get dialysis in the future and also can cause swelling of the arms and face. Additionally, blood infections are a non-trivial concern. And then there can be other issues in terms of clotting catheters when they're in too long. But basically, we do not want the catheters in for significant periods of time because long-term they're going to create other issues and other health problems. So the U.S. Department of Health and Human Services did an assessment of CKD a few years back, and they identified 14 goals to strive towards. I'm highlighting 3 of them here. One is the increased identification of people with CKD. As I mentioned, 90% of people with CKD don't even know they have it. The other is increased proportion of CKD patients who have a nephrologist before starting their therapy. This is very important because sometimes the guidance from the nephrologist can help manage some of these issues that don't manifest themselves as overtly early on. And finally, improving vascular access for hemodialysis patients. So notably increasing the number of arteriovenous fistulas for patients, reducing the number of catheters, and increasing the proportion of people who already have a maturing or matured fistula at the time of initiation of renal replacement therapy. So the current status of AVFs, about 60% fail to attain suitability, maturation. What that means is being able to use them for dialysis. From those that mature, a quarter to a half will fail within that first year. A retrospective analysis of over 500,000 patients concluded that functioning permanent access at the initiation of hemodialysis confers lower mortality. That means basically if you have functioning access at the time that you have to start that therapy, your overall mortality and lifespan improves. It should also be noted at this point that the AV fistula is not something that will last indefinitely. We call these permanent, but the lifespan is still limited. So patients will often have a fistula on one side and then the other side, or a fistula and then a graft on one arm and then going over to the other arm. So over the course of your life, while you're receiving this treatment, you may have multiple fistulas. So it's important to try to increase the options if that's possible. So ultimately, there is a need for additional complementary, not necessarily replacing existing, but adding new options for long-term hemodialysis, particularly patients who are not surgical candidates. Early access is better for patients overall, and the demand currently outstrips the option. So it's a supply-demand issue, and the supply is not meeting the demand needs right now. So with all the exciting developments with image-based procedures, minimally invasive procedures, is there something that we in the interventional radiology space can offer, or interventional nephrology, or minimally invasive surgeons? And it turns out there is. And ultimately what enables this is what I'll highlight and spend some time discussing are these upper extremity perforator vein. A perforator vein is a vein that connects the superficial veins to the deep veins. And we knew about these in the lower extremity for many years, but it's a relatively new recognition or discovery for the upper extremity. And this is the key that actually allows us to provide this option for patients. So the perforator vein, is cartoon outlines it here. The little railroad tracks splitting down here are your deep artery and veins, and the X or Y-shaped larger vessels up top are your superficial veins. These are the veins you're going to want to use for dialysis, and these deeper ones are where the brachial artery is and the radial artery are, and can provide that pressure gradient to drive the flow. This purple segment of the vein, that's the perforator vein, and that's the key to this, because in hemodialysis, the fistula basically connects the superficial system to a deep pressurized system, an artery, to increase the blood flow and allow your full blood volume to be circulated and filtered just within a few hours. So that's the crux, that's what we're trying to get done here, is to connect an artery that has pressurized flow to superficial veins that you can then safely place a needle in order to filter your blood within a reasonable period of time. So the percutaneous means through the skin, endovascular fistula creation. There are two devices, and I'll mention why I'm discussing both devices later. They operate on the same anatomic principle. They use slightly different mechanisms for creating, but the benefits are very, very similar in terms of the cost. The convenience where I refer to split flow is the number of potential veins or the extent of veins that you can actually use to cannulate for your treatments, and then some cosmetic and maturation potential benefits. This has actually been developed and matured for a decade now, and so the initial approval was seen in Europe, followed by Canada, and then the FDA approved this for us in 2018. I'll mention two of the trials that led to the approval of these two devices. The first device I'll mention is the Ellipsis device, and this is the study that led to its approval. It was a prospective single-arm study involving about 100 patients, and the outcome was really looking at functional usability, meaning could this be used for dialysis in patients, which was achieved for over 80% of the individuals at 1 year. No adverse events were attributed to the device, and so this study by Dr. Hull led to the FDA approving this device in 2018. The other trial, also prospective, involving about 100 individuals, different device but using the same principle, also achieved a cumulative patency over 80% and similarly led to its approval for use in the US. So, as I've already kind of mentioned, I'll hammer some of these points a few times, but the mechanism that is enabled is the same. It's this perforator vein. The benefits are the primary and secondary patency rates, so greater than 80%, which is great compared to the reported national average of 60%. It's a minimally invasive procedure with moderate sedation, meaning it's an outpatient procedure. You can basically do it the same day and go home, resume your normal activity. Multiple access sites, that refers to the fact that we've seen many patients depending on their anatomy, might have multiple veins that can be accessed for dialysis. And that ultimately results in longer use, longer utility of that fistula, which is great. Very, very importantly, it also does not exclude surgical creation. As I had mentioned, people will often need multiple fistulas or grafts over their lifetime. So this adds an option rather than taking it away or replacing it. And there are additional cost considerations as well, which appear to be beneficial. So without going through all the literature that's been discussed, as I mentioned, those 2 prospective trials led to its approval in the US. There have been subsequent retrospective studies, meta-analyses of this collection of these. The main conclusions are that endoAVFs are effective and safe. Additionally, they may be considered as a first option in the access pathway. Highlighting 2 of these plots here. These are follow-up from the individuals in Dr. Hull's original study 5 years down the road, with still over 80% cumulative patency and over 90% of essentially fistula use through the 5 years, which is fantastic. So when you come in for the ultrasound, there are certain standard measurements that we'll make. But in addition to that, we're also looking for some other pieces of information. Notably, does the patient have a perforator vein? So for context, the round and cylindrical objects here are the veins. So here are the deep veins, here's the perforator, and there's the cephalic vein, which is the superficial vein, which we would want to use for cannulation for dialysis. That same anatomy, now looking at it from a point of view of a venogram, this is injection of contrast, so everything dark outlines a vein. So it's injected in the brachial vein, we see the perforator, we see the cephalic vein, and we see the deep veins. The shoulder is up to the left of the screen and the patient's hand is down to the right. So after creation with the wavelength device, we see the fistula here. The artery is pumping blood out to that superficial, to the superficial outflow veins, the cephalic veins. Here's a picture immediately after creation with the ellipsis device. The initial creations with ellipsis are done just with ultrasound typically. But the mixed blue and red show the turbulent flow from the pressurized artery pumping it up into the perforator. And then this red vessel now is the arterialized, or that kind of the high pressure, high flow cephalic vein. So I'll highlight this later, but while we're showing some images and discussing some aspects of the procedure, the majority of patients will recommend a maturation procedure. So what are we doing and why are we doing this? We find that with the maturation procedure, we can improve the flows even more, which should produce better longevity down the road for the fistula. So in the maturation procedures, there are typically 2 options. One thing we may do is coil. So what does this mean? It means we want to redirect the flow from one of the deep veins to the superficial ones. The fistula is here. This bottom chunky vessel is a deep vein. We want it to go up to the superficial one. So we'll place a tiny, biologically inert microcoil that doesn't block off the blood flow. It just pushes it up so that there's more flow going superficially. And now you can see this is a much bulkier, at the top of the screen, bulkier superficial vein that should be great for dialysis. In some cases, in addition to the coiling, we'll also do some ballooning. So what does that do and why? Here's the fistula. Again, those deep veins, double railroad track or tram track on the bottom are the deep ones. Up top is the more superficial one. We want to push that flow higher. So first we put some tiny microcoils up here, and then we'll also balloon across. And now you see you've diverted the flow. It's more superficial. And again, this should be great for accessing safely and providing great dialysis. During quote, the maturation period, we'll follow every 1 to 2 weeks or so to see how that blood flow is developing. Again, it takes some time for this to mature. And with respect to the amount of blood flow, the numbers we typically cite are 500, 600, depending what the center is. But basically, let's say it's 600 cc, 600 mils per minute is what we're looking for. So about a week after, we're at 345, and 3 weeks after, we're nearly at 900. So at this point, we can actually recommend beginning to access and use the fistula. So who is a potential candidate? Well, anyone who thinks hemodialysis would be a good desired option for their renal replacement therapy. And then the main caveats really are having this perforator vein, which 85% of the individuals we estimate will at least have one perforator in their upper extremities, and then appropriately sized veins. We won't go into those technical aspects there. It's just when we do the ultrasound, we're going to be looking at specific things, doing some specific measurements to make sure that we think this will be a viable option. And of course, patients who are not optimal surgical candidates, of course, this would be a great option. In terms of the planning and follow-up, we'll outline this as 4 general steps. The initial consult, we'll do the ultrasound, have the clinic visit. If the patient is a candidate, we'll discuss the pros, cons, alternatives, and then answer any additional questions. If that all makes sense and it's a go, then we'll do that procedure as an outpatient procedure, as I had mentioned. Then the third step is a follow-up, where we do these follow-up ultrasound scans. And again, the ultrasound scan is not a procedure in itself. It's basically like a clinic visit. We'll have a little probe with some cold gel. We'll look at the veins, seeing if it's maturing along schedule or not. As I had mentioned, now in the majority of patients, I recommend maturation procedures, typically in the range of 3 to 5 weeks, just because it provides a more robust fistula for use. And then once that's ready, we contact the dialysis center and we get all that set up and coordinated. So here are some pictures from 2 individual patients. The first one on the left, 8 months after they've been cannulating, they're going to a different site, so we're just kind of marking the areas so that everybody knows what they should be cannulating and why. And you can see you can barely tell, so that's why we have to add the skin markers there. You could still palpate something. And here's another individual 18 months later. So it's nice that you don't have really big, lumpy, bumpy arms. It's still palpable for that vein that's a little larger. It might look like you work out a lot, but it's not these kind of unpleasant, lumpy, bumpy arms, which cosmetically is nice, but it's also very helpful for the lifetime of the fistula. And I'll also mention this thrill, and I'll bring this up again later. The thrill is this buzzing. When you connect the artery and vein, you feel this buzz. And that's something that we will recommend that you keep track of and just feel for yourself over time, just so you know, oh, is this feeling weaker or not? If it is feeling weaker, you can always reach out and we can investigate why that may be. But I also highlight this here because most, the surgical fistulas are typically above the elbow. Since we're using the patient's anatomy to create this, it's below the elbow. So you just have to be aware that below the elbow crease is actually where you'll feel that thrill. Procedure itself, as I mentioned, it's an outpatient procedure. We just use a tiny needle followed by small catheters to enter the vein and then the artery, make that connection, and then that should be set. Sedation we typically do with moderate sedation. We're not necessarily trying to knock you out, just keep you comfortable. In some patients, they would just prefer to have deep sedation. They don't want to remember it. That's fine too. We can do that if desired, and I'll frequently do a nerve block of that same arm, just again for comfort reasons. You can resume the normal daily activities later on in the day. If a nerve block was done, we typically recommend to do that the next day because your arm still might be a little numb. And then no extreme exertional lifting activities or anything like that. So then the post-procedure, no blood pressure cuffs on that same arm as the fistula. And the supplies that we'll provide are a wristband typically, so it alerts, you'll likely know, but alerts everybody else you have a fistula on that side. A hand cushion, which is actually very important for exercises. We'll recommend to use this 5 minutes every hour. In part, it's because once you have the fistula created, it's a little bit of a partnership. And the more you do these exercises, and they're not heavy or hard, it's just to do it frequently and to make your forearm muscle strong, it can improve the blood flow in that fistula. And then an arm sling if needed, if a nerve block was performed. During the time of maturation, while we're waiting for the blood flow to improve and everything, we'll put you on a blood thinner typically. And again, what we do encourage is to palpate that thrill daily, just to make sure you get used to feeling it and making sure that you can get the payoff for doing all those hand exercises. And again, at UCLA, we are a fan of the team approach. So of course, your nephrologist is involved in managing your care, the kidney care coordinator, dialysis center, and we try to help out and do our part by providing access for the renal replacement therapy. So I know I stepped through a lot of information here. Hopefully it provided some context and background. I'm sure if you have additional questions, we are always more than happy to answer them with the consultation. Please reach out to the UCLA Interventional Radiology scheduling team and they can set that up. Thanks very much for your time. Have a good day.